go.
Thank you all who are online as we are getting started. I'm sure some of you encountered some new Zoom features that we encountered also in getting ready. But we will be starting our presentation with Johan Sonnen in just a moment. I'm looking at seeing that people are starting to sign in as we speak, and we will continue to welcome the, here they come. Now they're coming in droves. I can see it now. Johan, as you said, we're victorious in bringing these people in. So thank you all. My name is Denny Brennan. I'm the Executive Director of the Massachusetts Health Data Consortium, and I'm very pleased to welcome you to our first webinar of the year. We are joined today by Johan Sonnen, who is the Director of GoInvo, and an outspoken, I can't say critic, but thought leader, I would think is a better term, on why healthcare needs to change in order to not only incorporate the patient, but to put the patient in a position of control, a position of ownership. We know that with 330 plus million people in the country, 6,000 hospitals, 1 million docs, 1,000 health plans and products, that we simply can't do this by mashing big data together. But we also know that we need to recognize the role that the patient plays in their healthcare, and in making sure that healthcare is rendered in a manner that they, as individuals, as ends in and of themselves, rather than means to an end, want to achieve with their health data. So perhaps we can go to the next stage, and I'll provide a little bit in the way of rules of order for us today. Please feel free to use social media if you're so inclined. You can see our handle, Johan's handle, Johan's organizational affiliation at GoInvo, and we've added the hashtags MHDC GoInvo, hashtag your own data, hashtag mass health data. All attendees will be muted during the presentation, so please enter your questions in the Q&A window. Chat is disabled, so we have the Q&A window there. We will wait till the end of Johan's presentation before we take your questions. We have a short time today, so we're going to get started in just a minute. Johan's going to do his presentation, and then we will follow with questions. We are recording today's webinar so that it will be available to MHDC members within 3 business days. If you're not an MHDC member and you're interested in receiving the information from the meeting, please contact Arlene Coletti at ACOLETTI@mahealthdata.org. And we can follow up with you on that. We will have a brief survey at the end of the meeting, and we can use that to get a sense of your responses and your thoughts as we go from here. So with that, I'm going to not take up any more of the airtime we've allocated to today's discussion. And Johan, I'm going to turn it over to you to introduce yourself and to take us through our discussion today.
Thank you, Denny, very, very much. I am Johan Sonnen, and today I'll be mumbling about how we as residents of the United States should own our data and how important it is to our health, and it should be added as a right of residency of citizenship. If you have any questions, I will love to talk about it. I'll answer them as I can. Sometimes I can't see the chat while I'm doing this. Just feel free to ping in the Q&A in the chat window. I am also posted my slides in advance. I'll do it at the end again too. Okay, so I pretend to run a healthcare design studio in the Republic of Arlington, Massachusetts, and I also teach at an academic center in Cambridge because we're in healthcare. Here are my disclosures. I wish I saw this more. Not that I have any money that I need a trust for, but I don't do any active trading. One, all of my data in the healthcare world, my entire genome is on GitHub. Download it, plant it at a crime scene, make sure there's a four-legged animal involved. I also have an academic appointment. But if you want to get a hold of me or publicly shame me, you can get a hold of me here. I'll try to get back to you within 2 business hours. Okay. I love this line. I wish it was still true because it has morphed to be healthcare as a noble business. Okay, I understand that. It is noble, but there are lots of blisters that I think we're using that nobility umbrella to cover. And let's look at a few of them. And usually I like to look at where the money comes from. So if we look at the 1 mile between the venture firm called MIT and the private equity firm called Harvard, that area occupies roughly 25% of healthcare GDP of the country. That's an insane concentration. Nature typically doesn't like that. But if you look at this on the global scale, holy smokes, it's 1% of global GDP in that 1 square mile. Okay, so maybe there's something we should investigate there just a little bit to see how and why that's happening, because I think we have felt over the past many decades the shift from human care to profits over people. And one example of this came out, I don't know, maybe 2.5 years ago through ProPublica, where it followed Jose, who's the chief medical officer, or was, at Sloan Kettering, a very, very good cancer institution in New York City. So what happened? Well, he was breaking conflict of interest rules left and right. This was basically the playbook of Arthur Sackler. So nothing new here. However, it was just egregious, just like Sackler was doing. And it goes on to talk about, well, look, there was a startup that came out of Sloan Kettering called Page.ai, an interesting company. It used models, algorithms based on the data, our data, to look in advance, basically create CDS, clinical decision support. But yet most of this is paid for by the public. The patient data is owned by the hospital. It's not just one clinician that did this. There are tens and tens of hundreds of clinicians that encoded, decoded the data. And guess who had the equity stake in this? Yeah, it wasn't the public. It wasn't the patient. It was the CEOs, the chairman, the board of the hospital. Okay, it gets better. This is not, again, a couple years of work. It's decades of lab work. It is, again, patient data owned by the hospital. And look, many of us still work at .orgs, and they used to be, or they tried to be, a bastion of, okay, how do we extricate ourselves only from the profit-making component of the U.S. economy? However, that's changed, specifically over the past 2 decades, where it's a huge shift, this land rush, gold rush for nonprofits to make money different ways. And this is one of them. So Thomas is hiding in plain sight here. It's always interesting when someone's a CEO and intern at the same time. But, Thomas aside, the main point here is that the data use agreement the hospitals use keep patients out of control by design. So, okay, what is this telling us? This one example, there are many examples of this, is that patients have no ownership rights over their data. It's funded by the public, yet who owns it? Who owns the patents? Oh, yeah, it's the executives at those institutions. This is corporate welfare at its finest, and it's really the ethics is situationally optional. So again, this is not indigenous only to Sloan. It happens here in Boston quite often, all over the United States. This is what happened, a couple of years ago. Here at Beth Israel, again, it keeps going. But let's use a very local example and new example with Tal Zaks, a Moderna CMO, who talked to Michael Milken, who has his own interesting background. On his podcast, Tal said, yeah, it's really, he does enormously important work. Don't mistake my Pierce at the money for that we don't need work on vaccines. I think that was critical work for the planet. But yet here he talks about, well, I want to be more effective. Well, what does that really mean? What does more effective in healthcare outcomes mean? Well, let's look at this very simply. The second Operation Warp Speed went into effect, the executives at Moderna and many other companies getting funding filed, if they're a public company, that they were going to take out shares every week. And Tal took out $1 million a week, starting 2 months after that initial injection of taxpayer funds, for a total of $100+ million. That's pretty egregious. And this continues to be a problem. We look at what the Boston Globe released, a month ago or so, talking about, well, Dana-Farber got their act together pretty recently with how they are funding startups, what their boards look like. Oh, I wonder why. Because the Boston Globe called them out on it and they fixed it. But then yet MGB, Mass General Brigham, was called out, and they're like, guess what? We're not going to really care. We're not going to do any new ethics rules for us because we know better. We can be trusted. I don't find that to be the case. You can look here at the data and the rules. Yeah, there are really very few, if any, especially for MGB. Now, it's a great institution. I'm lucky. I got my hip replaced there. I've gotten much work done on my humanity there. So I'm part cyborg, and I'm happy about it. But it's crazy. It's crazy to think that most of the leadership is technology and finance based, specifically for the gain of them and their companies. And this is something we have to change. It's just its own pandemic in the United States. And this was a great line from the New York Times. Well, obviously, we don't want these hospitals to become vehicles to make money. Well, yeah, no kidding. So it's a little disappointing. So yet we're all complicit. We're pushing our data everywhere, from Kendall Square to Moscow, willy-nilly. So how do we start to think about this? What is the road to getting a little better about how we handle our data? Well, our data, our health data, includes much more than we typically think it is. Here, many of us are, I saw that, we're coming from MGB or MITRE or other places. Probably that your health data is really any information about a person's life that helps in making better and better decisions. This was, by the way, an article we seeded on Wikipedia 5 years ago. It didn't exist up until then, sadly. But this is the one-liner that I like to use is, okay, so we look at our typical thoughts on health data, labs, hospital data, your genetics. It's much more than that. It is your salary is a health data point. Do you vote is a health data point. Other than the classic, zip code, where do you live is a big one. If you want a sort of deeper dive into this, you can go to our open source determinants of health visualization at determinantsofhealth.org to see some of the major components and vectors of what make up your health outcomes. And you can go here to determinantsofhealth.org. It's an open source project, by the way. Second, you don't own your health data, and you should. Look, if I'm not even going to look at HIPAA right now because it doesn't do anything in that regard, but let's look at GDPR, which is a little more evolved. In the recital 7, they talk about, okay, control and access, no ownership though. And then if you go deeper into the right of access recital, they call out, okay, you have access to it. Great. But it doesn't belong to you, and it should. And if you want to see all the tendrils of who sniffs and whiffs your information, this is also an interesting flow of, okay, great. So you're at your encounter. Maybe it's face-to-face, maybe it's remote, doesn't matter. But there are a number, hundreds of potential services that are looking at your data. And if you look just at how many services your voice travels through when you're using Alexa, for example, I believe it's over 500 different transitions and services that are part of that chain of you talking and communicating with Alexa. If you want to learn more about this, you can go to whousesmyhealthdata.com. Again, another open source poster. So my hope is that, okay, we're living in this age of healthcare surveillance, that it becomes something where data ownership turns into something of a net positive. That's my part fantasy. We've talked about this for decades. Other people have talked about it for 5 decades. Alex Pentland talked about it in 2016, but really it's the proliferation of this silicon brick in your pocket that has moved this much, much, much more forward and quickly. So we have some people on our side about this. Betsy Nabel, the former president of Brigham, talked about Asima Verma, the former administrator. Okay, great, fantastic. We're on the same page here. Oh yeah, this also happened in the meanwhile. Betsy's now had serious ties to Moderna in terms of ownership of stock, and we all have problems though. I am dirty in this, so it's not like all of us are peachy clean. Because I have worked for companies that do risk adjustment for huge populations. I've worked on all sorts of things. And when I look at my own career, so I can call out Ms. Nabel on this, but look, I too am guilty of being heavily tied to the industrial complex, military and healthcare in this country. Okay, great, but there is still a spectrum of dirtiness. So maybe, I don't know where I am on that, but hopefully a little better. But so back to owning your data. This is an excellent paper. It's a 4-pager, so even I could slog through it. And for some reason, JAMA loves to only have 3 people who authored this, but George was the key author on this as well. And it outlines 3 components to getting to data ownership. And that's 1, you need common data elements. Okay, good. Number 2, you need an encounter receipt. If you do anything with the health system, with your phone, with a human, with a community healthcare worker, there is a transmission of what happened. And then third, there's a contract that allows you to co-own or own your data in full, allows you to then control what's happening with your longitudinal health record. And Kathy Mick and Harry Sleeper and Eric and George make this really painfully clear in this one paper, which I highly recommend. But if we sort of looked at this as you have an encounter, I don't care what it is, face-to-face, telecare, whatever it is, you have an encounter and you get your receipt from that. You get this digital thing that shows up and says, this is what happened in that encounter. Then you have a service that then constructs that says, okay, I got the receipt, I ingested it, what's happening with it? Let me construct it, let me put it into your longitudinal patient health record. And then ultimately, this turns into lots of different views depending on your access. So for instance, you need a patient data use agreement that governs the access to these components, and some of them will be accessible if you give them to your caregivers, to your family. That may have a different kind of ring to it, to the state, because by law there's certain things that the state or the Fed need to see. So again, there are lots of different sort of slices of this and how you see the data. Now the patient data manager is something that really looks like a Tetris bot in this whole sort of scenario. Is it puts together your record over time. And that, I think, is a critical component to our healthcare system that doesn't really exist at the moment, and something we need so that it manages it for us, because no human in their right mind wants to do this manually. It's just absurd. Now, what do you get when you have a standardized patient record? Well, one thing is maybe you see how complete the record is over time, because nothing is ever full, but most are probably empty. And it's good to see if you walked into an ED, if you are looking at if you're trying to do self-care, well, what's missing? If a clinician is trying to help you with something, a nurse, well, what can we see? What don't we know? That's just one thing of many. Now, another side note is, I use a lot of graphics in showing people the problem set, and for my own brain, it works this way. And actually, it took a lot of overeducated MDs and PhDs to say, yeah, drawing pictures helps comprehension. Well, no kidding. But we do this a lot at the design studio, where we have to show and don't tell. And this is very good for everybody, for humans, because this graphic kind of evidence allows it to sink into our brain pretty quickly. And so we have a lot of examples of this, what we've worked on this past year, actually test, treat, trace. Imagine if we got that. And Charlie Baker just announced 10 minutes ago that 26 million tests were just purchased by the state. Well, if we did it right, everyone would be getting at least a test a week. That's only 4 weeks. So, okay, I guess we have to start somewhere. Next, this is, again, more visual work to show a concept. As for the Open Humans project, and this is for our open source care cards. Again, show, show, show. So let's go back to owning your data. When you own your data, you start to control access. So here's this sort of process of from encounter to longitudinal record. Let's just look at a few of these things. We have a prototype that we worked on with the MITRE Corporation. I think there's some people actually on the consortium, but also on the call today that may even been part of this project, where it's all on GitHub, by the way. And we made the introduction to how your data would be used and how you control it in a very visual, graphic way that a 5th grader could hopefully start to interpret. Kids need their own version of this too, because we're not teaching it in schools. I don't think I'm doing a good enough job as a parent with my spawn, at least I'm pretty sure they're my spawn, in telling them and teaching them how to work with their health. So we need these things to be engaging to all humans. And we used the Apple Health Kit to reside or on top of for this prototype, where you could see specific oncology work that you're having in your life, for better or for worse. Maybe even you could listen to the diagnosis when you went in and stared out the window as your clinician told you about your cancer diagnosis, and your mind goes out and you want to, let me relive that pain, but now I can listen to it in full when I'm concentrating. And then if you're a real data dork, you can swipe down and see where in the social determinants of health wheel your data resides, or what is there, what isn't there. Again, this is pretty nerdy, but it's not, but it needs different onion layers for depending on what kind of involvement you want with your health. So this is a prototype. It's on GitHub. It's open source, and it'll be actually evolved in 2022 as well. So the 4th point here is owning your data gives you health autonomy. So the idea of ownership rights is that you get to possess it. You can share it with anybody you want. It's yours. You get to sell it. Yeah, people I think can twitch about this, but if you want to do that, if you want to barter like we do now with our data, go for it. It's yours. You can do what you want. You can also destroy it. Sounds scary? It is, but that's yours to do. So here's the 4 points of data ownership that we see is that 1, you as a patient co-own or fully own every data point about you. Number 2, when the data is generated by a clinician and you together, you co-own that piece of data. 3, the data that you generate completely by yourself is fully owned by you, and you have the 4 rights to do whatever you want with it. And then all of these things, the uses of a patient health data should be consented in advance. So you know what's going to happen, and you should know what is required by law. Specifically, like if you come in with a communicable disease into MGB and Mass General Brigham, and then that has to be reported in some ways, but it's not like all your health data is reported, but there's some things in law that have to be. Now, there's a problem arising over the past couple of years where you have big healthcare systems saying, no, we don't want patient data ownership because we want to aggregate it and begin to sell it. Because, and here patients were not asked anything about this. They didn't get to opt out of Truveta. And I think this is insane that 40% of the Puget Sound region population is part of this database of patient data. And you have healthcare systems working together to compile all this data, of which they're going to share and sell. That's the key issue here. Yeah, and DC Medical News really talked about the commoditization, like we're treating this like Coca-Cola or coffee or coal. It's just a commodity. Great, thank you very much. So, and even, Northeastern Prof said, yeah, the DUA is the thing that's making this possible. The data use agreement gives us control to be able to do the hospitals whatever they want. So something else we need to probably think about is, well, do we need to create a new category of IP law where maybe it's like, time limited, like copyright? I don't know. Maybe we need public ownership of anonymized data so that the Truvettas of the world don't exist in their current instantiation. They may exist in the public's interest. That may be quite different. And then maybe this idea of the third-party aggregates that aggregates and holds your medical data becomes more and more true in the United States, and then you're directing it as a patient. You can see some examples sort of starting to burble along now. Open Notes has been around since the VA 2000 in the year 2000, and now has really taken off in this fantastic project. This is getting closer. Where's my medicalrecord.org? Fantastic. It also needs a data ownership vibe and a standard personal health record to really get everyone on the same footing. The FTC, relatively recently put out some new guidance about how data being exposed to the public or being taken has a small fine associated with it. If you're big enough, 43,000 is something you sneeze in a few moments for the Googles and Fangs of the world. But at least it's something. I think it would probably order of magnitude difference would make something more interesting there, and actually policing it. And MITRE had the fortitude to come out with, at the end of last year, oh yeah, we need ownership. Holy smokes. MITRE is not necessarily known for being an outwardly progressive company, but they do some interesting work. And this was a surprise to see, and excellent. So if you want to read a little more about this, Data is Property, Own Your Data, and it's a good book. Mine gives you some of the legalese in what's happened across the past few decades, and some good examples there. So any healthcare system that doesn't give you your data is mistreating you. It's the last frontier, is the human mind. And, the surveillance capitalist mantra is, how can we screw over the people without them knowing about it? Because we want to make more money. This is a little depressing, but let's see how we can get out of here, because we need to demand data ownership rights. And if you're interested in this, you can go to a MITRE project. This is datauseagreement.org. It goes right to GitHub, to a very readable one-pager and the 8-page version of the DUA that puts the patient in control of their information. And why is this on GitHub? Well, GitHub, for its open source projects, has open code or open design or open things that are in the repositories there. It's licensed with a business-friendly or viral license, depending on what you want to do with it and what the owners want to do. And then the third part of being an open source project is you need the community to buy in or see it and grow the feedback loop there. So why are these interesting concepts open source? Well, the fifth tenet here is that you really can't solve healthcare until you ask the people to participate. And this great line from the Declaration of Geneva from 70 years ago tugs at most of my heartstrings. And yet we have, the PBMs of the world going, yes, we still have our black boxes and their algorithms that learn how to siphon more and more money out of the system. Great. Because I think I tend to want to have healthcare as a human right in this country. Maybe we're inching closer, but we don't, because we typically don't even know how, as a healthcare service, when you use it, how it works, why it works, who it's best working for, and if even the evidence or results are true. Because most of these things are black boxes. So if healthcare is so noble, if it's critical to our life on earth, and we really don't have a choice in this country, we demand healthcare to be open. So the internet, at least the infrastructure, is uses a lot of open source, and the UN has declared it a human right as well. But if we look at the OSI model, open systems interconnection model, that engineers like to sort of roll out occasionally, most of the infrastructure and the protocols for the internet are open source. And there's loads of examples of that, tons. And half the people in the planet, more than half, 2/3, have Android devices in their pockets. Now, on the healthcare side, though, if you look at a similar kind of stack idea, it should be open source, but we have mostly closed health IT. And Eric Topol calls this, we have anti-open source in healthcare. Again, we have people on our side that, heck, Epic, we need an open source EMR. There are some like OpenEMR, for example, but we need something for another investment in health IT as an open service. My homeland of Estonia has an open source backbone for their health network. That's called X-Road. But again, it's easier to sometimes do something with 1.5 million people than it is 330 million people. But it's a good example to look at. Now, there are some burgeoning open source projects over the past decade that are helping in this arena, but we need to do some more. Now, open source healthcare is really suited for a couple different components and domains that we play in. One is infrastructure and leading edge things, but also global emergency. And you can see it more and more. It's funny. It's my inbox now, or in my newsfeed actually has open source healthcare for the first time ever in it. The defining some of the vocabularies and the terms in COVID, fantastic. Also open source projects. There are 125,000 repos. I'm not saying all of them are good. On GitHub, a date picker, which is a big deal. Well, it's not a really big deal, but there are a lot of date pickers, maybe 7,000 on GitHub, and now we have a lot of them repos on COVID in GitHub. So, and there are lots of projects here that have started and helped with how do I get my vaccine records? Mostly open source here. I wish Common Health was more open source, but they have open source tendrils. And Sarah Alert, COVID Shield, COVID Green, excellent projects. We at the studio, all the things we produce inside the firewall are open source. And you can see some of those here. And let's keep going a little bit, is that, look, the coalition around COVID and the technology and the health IT underpinnings of it has an actually open source in part of their governance. I think that's fantastic. And yet we need to do more. It's probably too late for Marching rights. I know it's too late, but we should have done Marching rights on the vaccine patent. Maybe there was just a time limiter on the patenting. Maybe we should have had I know we should have had some kind of open patent so the entire planet can get in on this, have a different kind of distribution model. It is a global health problem, and yet we're treating it like a corporation trying to be nice. And that just typically doesn't work unless we have bigger levers and bigger crowbars. But that leads me to, what's your own agenda for the country? Have you mapped out what you need to do? What is your business doing? What is your nonprofit doing? And so this is my list of things I'd like to see as part of healthcare policy in the US. And we actively look at, well, how is this aligning to the projects that we are doing? How are we not taking up projects, if we're lucky enough, that go against this? And these blue sort of borders are the things we actively work on, at least over the past couple of years. But you need an agenda. You need some kind of understanding of what's happening at the national and state and local levels in terms of policy, in terms of what's happening, in order to see, are you going to make an impact? So we have our own here at the studio. Okay, some are very sort of more tactical, some are more fantasy. That's my, Ralph Nader or Senator Liz Warren hat on. But this is something that we're actively going for to match some of our needs and hopes for the country. And then you really need to see, well, what's the system engineering that needs to place? Because healthcare is just one big giant component of what's happening in the United States right now. So look, voting is healthcare. If we can't get that right, you think our healthcare system is going to get better? That's probably not. So this is kind of the idea that where you need to see things in context of bigger and bigger vibrations. And part of my thing is, well, who the hell are we going to get for that replicates the Stacey Abrams vibe for Medicare for All? Okay, so we have to be deliberate in committing to open source. We do that. We invest what little profit we make directly into open source projects. We do that every year over the past decade. We try to also adjust how we do work with open source clients and projects as well. Okay, and we're grateful for their participation and funding. So what was our agenda for last year? Health picture, Linux Foundation, US healthcare problems. You can see all these things some other time, but I'm just going to do this last one here about owning your healthcare data. We started this mid last year, and we're continuing it for how do we get patient data ownership for the state of Massachusetts. It was the canary for ACA and Obamacare with Romney Care. And we think that it's a good state to try and get this passed. If you're interested, we have a graphic novella that outlines the story in visual terms. We also have a light paper that accompanies this for those who want, the 45 different references. And you can see all of that at Own Your Healthcare Data, ownyourhealthdata.org. We're now roping in local representatives, and you can see our stat news piece that was published 6 weeks ago at ownyourhealthdata.com. So lastly, just to wrap up here, and I'm sure I'm ready for all the arrows and slings that are coming in. Healthcare and public health are a utility. They are really a human right, and they're way too important to be closed. And just to recap the ideas here is that health data is way more than we think it is. You don't own your health data, and you damn well should. When you own it, you can control it a little better. It gives you health autonomy. And you really can't solve this bigger problem without others, without building community. And finally, having health data itself can save your damn life. I've stolen from most of these people here and thankful for their contribution. And if you have any questions, you can email me here and you can see my rants on open source healthcare there. Thank you very much.
Johan, thank you. That was outstanding. And we have time to take a good number of questions that have crossed the transom while you were speaking. Let's just start with one question we have that was fascinating to us is, can you describe more what your social determinants wheel is, that wheel of influences on health a little bit further?
Sure. That wheel, we do a lot of circle diagrams for some reason, but that one is it outlines or tries to outline. Let me pull it up while I'm talking about it here. I'll just share this here so you can see it. What this is it looks at the major variables of our life, the major things that we do, whether it's or have in our bodies, what we eat, our behavior, our social circumstances, our genetics and biology, the care that we get, the physical environment. All these things have impact on our health outcomes. And this needs to really be a dynamic diagram so that, hey, I live here, my salary is this, I have this kind of condition, boom, that should then redraw and tell you, this is really what's happening or potentially is the outcome for you. I mean, right now, physical environment, you don't think that's going to change over the next 20 years and has been changing? Where you live on the coastline of Florida or Massachusetts over time is going to be much different. Our crisis of climate is changing that dramatically all the time. And so you can see this is well researched, and has lots of references, and it's been used all over the place. So you can see that at determinantsofhealth.org. If you want a physical copy of this poster, I will send you one. Just email me.
Thank you. Another question we have is, we're in the middle of an interoperability push where payers, providers, and as you pointed out, under Seema Verma, the Centers for Medicare and Medicaid Services added the patient as the third wheel, the third leg of that stool, I should say, and in so doing, positioned the patient as a central part of the data sharing requirements that are embedded in the interoperability rules. How do your thoughts, your opinions, your insights into patient data ownership jive with this interoperability push? Where does the patient sit as health plans, healthcare providers begin going through this arduous and big data process of sharing data? Where does the patient sit in that particular transformation?
Well, Seema, actually, she was on the right side of the argument on this particular thing, where she said, patients need to own their data. I usually, they are an atomic unit, the patients. They need to be able to say, yeah, go that way with my data, and be in control, say, yes, articulate what to do with it. They typically, however, we typically are not very good at that. So I'm getting to the data interop thing in a second, because it ties into this. Is they're not very good at, and I'm not very good at, how I'm going to plan my life. Humans have a real hard time with that in the next couple of days, let alone weeks, months, years, and seeing how we change over time. It's just not something that we are good at. So we're going to need lots of services to help us with that. And that's where the interop comes in. I mean, one of many places is if we have a common data elements that are used across the country, across the planet. That may be too much to ask. It's too much to ask in some ways for the country, but we need it. Then all these services can get a common representation. Can then, help me with, okay, dealing with my blood pressure, dealing with my 5 other conditions with my life. They're then using the same kind of definitions of data and the same look into my data. If I give them permission, and they're, I have the right rights and I want them to, then it becomes a much more level playing field for me as a patient. And it also then becomes easier as a business trying to make interesting services for other humans. So I just think it is nationally critical to keep on the interop bandwagon. I know many probably on this call are heavily involved in that. But US CDI version 1 was a sniff. The hope is that US CDI V2, V3, VN gets much, much, much better. And so we have a core set of, I don't know, whatever it is, 3,000 data points that at least can be used for most primary care. For, there's some oncological ones in there, but if we need a common set of the basics, then I think we'll get somewhere much better with services for everyday humans.
Excellent. Thank you. From Barbara Rabson, a friend and colleague, should there be permitted and non-permitted uses for my data? That is, without my permission. I'm less concerned with my data being used to track COVID rates by population groups, but more concerned with data being used to make people rich.
Spot on, Ms. Rabson. Hat tip to that question, because a couple things. One is there's some on the legal side. Oh, this gets to a whole bunch of questions. One is, yes, of course, you should be able to
I think we need a little more of your microphone, if you
We
can.
need
There
to
we go.
dial in specifically how my data is being used. If you want that kind of fidelity to say, don't go here, don't go here, go here, go here, you should have that synthesizer or nuclear power plant type, I don't want that user interface, but that kind of control on every single nugget. If you want it. There might be also much easier ways to say, hey, my core data, if science and the public good want to use this and there's some model for how you want that packaged, this patient data manager should have a few profiles like that available to say, yep, of course, if they're open research, open science for the mass public, go for it. You can use these core data sets or whatever you want. And then if you don't know who they are, or if you know who they are, you just siphon that off. Of course, that should also happen. But maybe Barbara's also getting to a question is, as a resident of the US, what data should be available for all citizens, all residents? Is there 3 data points about me that, is part of my citizenship, part of my residency? I don't know. That's a tricky question. And a good one, but that gets to a more public health vibe that I think we need better rules on and better citizen participation in.
Question from Joe. I often hear that we do not have consent-based systems in place to segment patient information to allow the type of granular control you're advocating, which Joe is a huge fan of. Is this correct or an excuse? If so, what is out there that people can look at, build off of, and learn from?
Well, consent-based systems. Well, I'm going to say that outside the hospital, no one, this is a common thing. No one reads their terms and conditions. The terms and conditions are designed to be terrible by design. So there are several, so that, you consent, I consent to most of the stuff on this thing, right? And you, for the most part, you have no idea where things go. So you're right, Joe. We're sort of doing it blindly and very badly. Hospitals have a few more notches in the control space, again, per reg, but they're pretty bad. Have you seen, actually the NIH program, All of Us, has one of the better consents out there, and that's based on Sage Bionetworks consent work, where it's actually videos and telling people what's going to happen. But again, we don't have insight into what people understand about it. You can't read someone's brain yet. So on one side, you have the Sage Bionetworks of the world doing a pretty damn good job of the basics. But on the other side, the commercial side, it's a wild, wild west, but with the huge advocacy for the corporations and using your data against you or for you or whatever they want it for. So what's out there that people can look at? You can look at Sage. That's pretty good. Is it the Light Coalition? Has a few governance rules that are pretty damn good in terms of what do you do with groups of people and how do you tell them and show them what's happening to your data. So they've thought about that for the past couple of years. I think Susanna Fox, the ex-CTO of HHS, is on that crew. So that's, again, it's pretty slim pickings. You may know many more than me, which would be good to hear.
Not off the top of my head, but I'm going to be putting that in my list of to-dos, certainly. How would you respond to the concern that by giving patients ownership, as you describe, you're creating an obstacle for health equity research? I say creating an obstacle because it's unlikely that individuals who choose not to share their data will be randomly distributed among racial and ethnic groups.
Yeah. Yeah, so let's even just look at what's happening now with research and I'll go back to All of Us again. They have made a concerted effort to make sure they get a diverse population in their research data. So they have gone for now, 2 years or 2.5 years, where actually the data pool represents the United States pretty damn well and actually tips the scale for those underrepresented humans. So it's not all the male, pale, and stale variety, hand me a mirror, that's donating their data to science. right? So that's a pretty good example right there. But there's a thing like money. I actually think let's not shy away from the idea of, hey, as a research organization, I should be able to go out and ask people, hey, I will pay you for participating in this. Not just taking it, but I'll pay you for your valuable information. And then I'll make sure that, depending on who's paying you and what their outcomes are, if it's a hospital or academic research center, they'll say, hey, we're not going to use this for nefarious purposes. And this fiduciary will be financially responsible for that. So I think it's a tricky question, but one that, we can look at all of us, what they have done in this space to slant it for better by their strategies of how they approach people, how they ask for it, what the benefits are. So I think that would be one program to look at. And I'm sure, again, there are 20 others which are doing a better job.
One of the means of creating a connection between patients as individuals and as communities in sufficiently large numbers to be represented is the health data trust. That has gone in and out of favor over the years as we look at technology solutions to deal with how information gets organized and how ownership and the use of data gets transferred from organizations to individuals. Could you talk a little bit about the concept of a health data trust and whether it remains a relevant concept or that we need to look at a different way to find a bridge between individual patients and the researchers, institutions, entities that want to use their data?
Yeah, whether it's a trust or not, I'm not quite sure. And there are probably going to be many models of this. So, I think you mentioned, Denny, that it's been tried. I think Switzerland has had two that may be that are still active in terms of data trust, where it's like a co-op, where they're a fiduciary, and you can push your data to put it inside of their data trust. And then as a group or individually, you say, this is what you can do with it. In order for the co-op to make money, you have controls over your data only, not of the groups, but your decision can bubble up. And they provide some profiles of, this is the kind of things institutions will ask for. You say yes to it, no to it, whatever it is. I think the idea that someone's financially on the hook to protect your data on your behalf, I think is critically important. And so I think that idea has serious legs, because also people care more about money than they do their healthcare, sadly. Mm-hmm. So I think it is a big crowbar for both commercial entities, nonprofits, and just being a human in the US. Money matters, and it's not something we should shirk away from because we deal with it all the time. It's like, death and money, people don't want to talk about it, but this is exactly why we need to talk about it.
Agreed. Another question sort of somewhat related to that is, why haven't, we live in a fiercely competitive economy where EMR vendors are fiercely competing with each other, with Epic on the hospital and large side.
Well, is anyone competing with Epic?
That's probably, I'm probably okay. Giving more credence to competition when I say that than I should, but it strikes me that there is an opportunity here for electronic medical record vendors, for not-for-profit health systems who really stand by their not-for-profit jobs, and we have a number of them in our community. And why isn't this a competitive thrust? Why isn't it that if I go to a particular hospital and I see a particular primary care physician and they are using a particular EMR where patient ownership of data becomes central to that, why isn't this becoming something that other organizations are using to compete? Why wouldn't an organization that wants to share my data with pharma not say to me, we would like your permission and we will pay you a stipend, a remuneration of some level to to have you participate. Surely that would increase the volume and the integrity of the participation process, the data sharing process. Why aren't organizations doing this to stand out as better citizens than their contractually bound, we've hidden it in the terms and conditions, competitors they have?
Well, it makes no business sense for them to do that right now when they can do it for nothing. If they can ignore that, then they don't have to pay for the infrastructure to do it. So that's a pretty easy economic thing. If there's a pretty good book about this, is it My Body, My Data? I know he stole the Gloria Steinem, I think she wrote the original, which I'm not crazy about them stealing that, but it's a good book that outlines the law and the commercial vibe of why this has happened over time. And they didn't have to. You don't have to do it. IMS just walked in the 50s into local pharmacies and talked to pharmacists and asked them to fill out papers on what people were getting prescribed, and they would just send it in for nothing. Eventually, IMS started paying. Well, this is one case study in the book. Would just start, occasionally sending them a couple bucks a month for their time, and then it became the typical thing you see with, and then they were just sending patient data for decades, just because they could, and they'd make money, and it's just part of their process. So I think if just by involving patients, you have another barrier to getting stuff done in there, and that's the way they're looking at it, and they can make money elsewhere. I mean, that's a pretty easy design choice.
But it does come with, in the current climate, wouldn't you consider there to be risks?
Sure.
An increasing level of risk to leaving the patients out of the discussion?
Yes, you're seeing over the past, I think, decade and a half, maybe more, of patient apostles and advocates, and data advocates, data rights, those who are fighting for data rights, voting rights, et cetera. This is coming to a head. It doesn't feel like, however, Congress is going to do anything about it. If we can't get basic voting rights hammered out, data rights seems like it's going to follow it. That's my concern.
All right, we are nearing the top of the hour. At this point, we would like to release a poll and have folks. Johan, you can close your eyes if you don't want to see the results as they appear on the screen. I'm kidding. Most people want to watch them. Truth works. So if Lynn or Arlene, you can release the poll, that would be great.
Hey, Denny, can you hear me?
Yeah.
Hey, Denny, we moved the poll into the survey at the end of the meeting, so that way we don't scare Johan and seeing.
Okay, so we will send it out we will send our poll out after the meeting.
Yeah.
If Denny, Johan, if anything, I would like feedback, if anyone's in the crew, in the audience still, on how to make this better. This is nowhere near ready for continual prime time. So evolving this is pretty damn important to me. So fire away with feedback at any time. I would really appreciate it.
We will do that, and this is an important part of MHDC's strategic focus going forward. Is how do we bring the voice of the patient into our discussions, into our board, into our meetings of our data governance collaborative. So I think you'll be hearing from us as we move through the year, as we understand more and more of how to make the patient's voice an integral part of what we do as a business, we do as a not-for-profit. I'm going to see if we have any final questions. I think we're all set. Ladies and gentlemen, thank you very much for participating. Johan, it's a pleasure as always. I appreciate your joining us today. And we will be sending out a survey shortly to get your thoughts and questions. And please provide feedback for Johan, because this is complicated, complex. It's incredibly important. And we can't do it without, as you pointed out, I think in the most pragmatic sense. If one looks at this with a hard, cold eye of a pragmatist, we can't solve the health data problem without engaging 330 million people and making it work. So with that, I want to thank you all for joining us today. Wish you a good, albeit cold day, and we will be talking to you all soon. Thank you all. Our meeting is adjourned. Johan, thank you.